Thank you all for joining us for Grand Rounds. I'm a poor substitute for our current sleep surgery fellow, Josie Shu, who has been traveling around this week as she looks at places and where she might be accepting a position for next year. And so I'm subbing in, but she'll be joining us, I believe in April, to give, and I'm sure it'll be a much better talk than this. So I wanted to speak just in the interest of not having overlap and providing something that's at least a little bit new for some of the talks that I've given to the department before. I want to speak about some of the future directions in obstructive surgery. Hopefully not too much pie in the sky, but things that are here and are useful going forward. So I a number of companies and have some crazy ideas myself, but the only disclosures that are relevant to this presentation are some research funding that our department and the institution received for some studies involving the Aspire Medical Systems device that I'll be discussing, and then for a company called Nyxoah in the hypoglossal nerve stimulation space, and I'll just briefly be mentioning their work and their approach. So I'll be talking about obstructive sleep apnea, surgical evaluation, including drug-induced sleep endoscopy, which has been the focus of my, a major focus, I should say, at least of my entire career. As far as going forward, there's obviously some discussion related to that and where we're headed with surgical evaluation, but I'll be talking about hypoglossal nerve stimulation, where we are now and where we might be going forward, and then some interesting work that I've been doing, building on some work that's been done for decades by others, looking at endotypes and endotypic traits. So obstructive sleep apnea, I know many of you are familiar with it, but to bring everybody a little bit up to speed, it's the symptomatic repeated upper airway obstruction occurring during sleep. And so it's breathing when people are trying to breathe during sleep. And the diagnosis is made through a sleep study, and the severity is quantified based on the apnea-hypopnea index, basically the number of times per hour with blockage in breathing. Normal is felt to be 5 or less, and there you see the categories for mild, moderate, and severe obstructive sleep apnea. The consequences include snoring, which is honestly one of the major reasons people seek treatment in the first place, but there can be health-related consequences, primarily cardiovascular, endocrine, and there's even some evidence of an association with certain types of solid tumors. But basically, those health effects are most clearly demonstrated for severe obstructive sleep apnea, not as consistent, the findings for mild to moderate sleep apnea. But what can occur, I should say, across the entire spectrum of severity are the behavioral consequences related to sleep disruption. So we're talking about sleepiness, fatigue, difficulty concentrating, and just really getting the most out of life, which is what we all see as we are often running around sleep deprived. But these people are facing this every night because they often, not always, but often can be have such sleep disruption that they really can never get a good night's sleep. So this is common among actually children as well as adults, and the NIH estimates that it affects at least 18 to 20 million American adults. That's an estimate from a few years ago, and with the worldwide obesity pandemic, those numbers are growing in the United States as well as worldwide. A recent paper estimates that this affects between 900 million and 1 billion adults across the world. So it's a pretty common problem. As far as treatments, we always start with conservative options, and those include the behavioral measures of weight loss, avoiding sleeping on your back, and then avoiding alcohol and other sedatives, especially within about 3 hours of bedtime for alcohol. We are surgeons, and so we play a role offering surgery for patients, and there are, our next talk is from a dentist, and basically dental oral appliances, ones people can buy over the counter, but there are custom made devices, and those are an important treatment option for many patients. But the real mainstay of treatment, certainly the first line option for patients besides who need more than conservative measures alone, is positive airway pressure therapy in its various forms shown there. So CPAP, or continuous positive airway pressure therapy, BPAP, or bi-level positive airway pressure therapy, and then really what is the most common modality now, which is automatically adjusting CPAP. And so what it is involves a device shown here. It's effectively an air blower, and the automatic adjustment of it is that it delivers pressure and responds to patients, and the algorithms are pretty decent for most patients, and responding to them and delivering what they seem to need. And typically, while the old-fashioned approach was to get someone on a single pressure all night long that was determined from an in-laboratory sleep study. Actually, now these machines, they have pretty decent sensing, and they can respond to someone who, for example, may need a little bit more pressure delivered to open their airway when they're sleeping on their back versus their side. Maybe a little bit more pressure when they're in deeper sleep, especially REM sleep, where they're dreaming sleep, compared to lighter sleep. And these machines respond during the night. There's not a huge variation usually, but actually the variation can be quite substantial when people do things like gain or lose weight, or position. It definitely can be a bigger one than sleep staging. But it's really nice that you sometimes need to tinker around with it, but the machines work pretty well in delivering the pressure that people seem to need. And the way it works is it's the term that's used as a pneumatic splint. And so basically it's air blowing in to blow and keep the throat open, almost like you blow up a balloon. And it's delivered from this system here, this machine here, to tubing. And here's the end of the tubing connecting to a mask interface. There's no single best interface. It's basically, this one is one that we place over the nose, but they can also be placed over the nose and the mouth together. And they can also be almost, not really a nasal cannula, but form seals on the nostrils, what are called nasal pillows. And there are other modalities as well. Some include mouthpieces, some really cover the entire face, but these are the most common categories are those three that I mentioned. And you see a headgear that holds it in position on a patient's face. But certainly this can work for many patients, but sometimes it doesn't work. And so for the most common role of obstructive sleep apnea surgery in adults are those with low adherence or benefit from positive airway pressure therapy. There are a lot of arguments about how common that is, but the people in sleep medicine, as well as other fields, would agree with that it's in the neighborhood of at least 30%. And so it's again, a huge number of patients. And so you treat those patients with obviously the behavioral measures. And in addition to those, the options are doing nothing else, which sometimes is the right choice. But that's when we think about surgery and these oral appliance mouthpieces. And so we want to improve apnea-hypopnea index, but really often we care about improving the signs and symptoms of the disease. And it's crazy that you think that treatment is going to solve all the health problems, but it turns out that positive airway pressure therapy, and maybe true for other modalities as well, they may not actually provide that much benefit when we're talking about cardiovascular health. So, blood pressure changes, preventing cardiovascular events like myocardial infarction and stroke. And so it's something that we have to be realistic, because it's not like treatment has not actually been shown to reverse all of the consequences of obstructive sleep apnea. Certainly weight loss would make it go away in the first place, but giving CPAP to someone with severe sleep apnea, it's a little hard to tell them that the health risks have disappeared. But certainly it's probably better to treat it than not to treat it. And of course, if you're improving their other signs and symptoms, then you're getting a lot of benefit regardless of whether you may be preventing cardiovascular events. So this is the slide that I showed many times, and really it's the cornerstone. It's actually what brought me into the field in the first place. It's the idea that not all patients with sleep apnea are the same, and we have procedures that work differently in different types of patients. And the question was always, why do they not work as well in some people as they did in others? And so here are two patients with obstructive sleep apnea. This is sort of the stereotypical middle-aged male, a little overweight. And this woman, thin woman, people would never expected that she had sleep apnea, but her sleep apnea was awful. And of course, those of us who are, otolaryngologists, we understand that it's probably related to her very small mandible. And so she actually, we moved to one of the more involved procedures when I was doing maxillomandibular advancement. That's what we did as a first step for her, because that seemed to really address the underlying cause of her sleep apnea. Whereas this guy did very well with isolated soft palate surgery, even though from the outside you would expect that he would be, sort of need a more involved approach. We obviously evaluate patients, and looking in the mouth, you can see that this patient with tonsils that we would grade as 1+ in size. There's a younger patient, you can see the braces, but that patient's very different from the 4+ tonsils that we see in a patient that did great with just isolated tonsillectomy. So people differ. We have a lot of clues, but this is what intrigued me to get in the field in the first place. And so I think that I did certainly not discover this idea, but there's quite a bit of evidence that when you look at sleep apnea surgical procedures and results, that effective surgery must be directed to the site or sites of obstruction. And here's a slide from my website where we think about the upper airway and this artificial distinction of these three regions being the nasal region, the palate region, and then what's often called literature is hypopharynx, but I call it the tongue region on my website, but probably a better term for it is the retroglossal or retrolingual region. So I'm not going to go through all these different procedures, but there's certainly been an explosion in procedures. On the left side, the first column is various things that are used for sleep apnea and snoring to treat the soft palate. This group of procedures here is used to treat the hypopharyngeal or retrolingual region. And basically one of the things that was exciting in the field is, and approved in 2014, is a hypoglossal nerve stimulation. And the main technology that's FDA approved, the only one that's FDA approved now, is upper airway stimulation manufactured by Inspire Medical Systems. We still have maxillomandibular advancement. I don't perform it anymore, but we certainly work with oral surgeons here in Los Angeles and elsewhere who are performing this and doing, achieving nice results. Not 100% by any means, but nice results in many patients who need this procedure. So the idea of this being important, again, motivating me to get in the career, was based on this landmark sleep surgery review, published now about 25 years ago, where uvular palatal the traditional approach, was successful about 40% of all sleep apnea patients. And the results were better if patients were the Fujita type 1 patients with obstruction primarily at the palate, and they were only about 5% response rates in those who were these type 2, type 3 patients who were felt to have obstruction down lower in the pharynx, in that hypopharyngeal region. And so one of the major conclusions of this study was the failure to identify sites of obstruction as a principal factor in poor results for surgery. And I keep showing this. I mean, it's obviously ancient, but this kind of thing that I saw when I was a medical student, because I was still in medical school when this was published, when I was rotating through otolaryngology, for those of you who are medical students here, it was like, shocking to me that we were doing something that was sort of mediocre. And we sort of had to throw up our hands and say, what do we do? We're just going to try with this procedure. And I honestly thought that we can do better. And so after I finished up my residency, around that time, the Cochrane Collection was reviewing the literature in sleep surgery. And one of their major conclusions, they sort of threw up their hands and basically said more research should be undertaken to identify and standardize techniques to determine the site of airway obstructions. So the idea was that, we had a lot of work to do, and sleep surgery still is something that people say, like, it's completely useless. It's just sort of a roll of dice and all that kind of things. So I hope to show you that we've made a little progress. And part of that progress was based on the idea of, hey, how do we figure out where people are having airway obstruction? So natural sleep endoscopy was developed in the 70s, and it obviously takes the fiber optic endoscope shown here that we use all the time, and basically having people fall asleep naturally and looking, through their nose, looking at this palate region and this hypopharynx. And so for a long time, the only two publications were from 1978 and 1982, which, might not be surprised, because it's difficult for someone to fall asleep naturally with a scope in place. And of course, if you're moving it around, that can be pretty stimulating and not that comfortable. It turns out I was involved in some work by the group at Brigham and Women's in Boston, Pedro Genta, a visiting Brazilian researcher, and who's now back in Brazil and continuing this kind of work. And so they've published a few papers on it more recently. And then a Korean group published as well, looking at natural sleep endoscopy. But these have been done in the research setting. It's not really so practical for most patients. Instead, as many of you unfortunately know all too well, I've done a lot of work related to drug-induced sleep endoscopy. The concept behind this was developed in multiple centers in Europe and first described in 1991. So we're talking still ancient history. The idea is that you perform fiber optic examination of patients under sedation so they can tolerate the scope. And you certainly don't diagnose sleep apnea, but to reproduce those patterns of sleep disordered breathing that are already seen on the sleep study that's done, of course, during natural sleep. And so it's got some growing use in the US. I'll explain a little bit more later on, but it's a big excitement. I'm proud to say, it's becoming accepted enough that I wrote the application to get a new CPT code that was supported by the Academy. And as of January 2022, there will be a code. Now, how much the valuation will be, who knows, but at least it'll be something where it's not quite as much in Never Never Land. It's something that actually is growing use in this country for a variety of reasons. So with a couple of European colleagues, for a long time, this drug-induced sleep endoscopy was sort of, just everyone had their own way of saying, this is what we saw. it was their own classifications, and there were varying degrees of complexity, and sometimes it was even hard to understand when people described in papers how they were describing things. Every possible combination of findings that people tried to say that there were only 6 kinds of combinations of patterns, but we didn't agree with this. And so Wilfried Hohenhorst and Nico de Vries in Germany and in Holland respectively, we came together and developed what is now sort of the worldwide standard about how we characterize findings. And it's not that creative of a name. The VOGT classification stands for, V is for velum, or soft palate in the area up high in the pharynx, but O is for oropharyngeal lateral walls, T for tongue or tongue base, E for epiglottis. And for each of these structures, you have to get a qualitative judgment of what is the degree of obstruction related to those structures. This is a structure-based approach. And for each of these 4 structures, it's no obstruction related to that structure, partial, or complete. Complete doesn't necessarily have to be 100%, but it's got to be pretty substantial. I'll be showing you some videos that you may have seen before. But with each of these structures, there potentially could be a difference in the configuration. So for the soft palate, it collapses in a front to back or anterior-posterior configuration. You can get collapse in a side-to-side pattern primarily, which is a different configuration, and then a combination of anterior-posterior and lateral, which is the concentric. Now, some structures like the oropharyngeal lateral walls, they really just collapse in a side-to-side or lateral pattern. The tongue really just falls back, so it's more of the anterior-posterior configuration only. The epiglottis primarily falls back, but there are some people that get almost like it's a folding of the epiglottis, and we call that the lateral configuration of the epiglottis. But here are some videos going through these different patterns. V stands for velum. Delay here. Should work. It's really shocking. Okay, so why don't we do this? I'll play the video separately. I converted the format and tested it, but here we are. How about this one? So the orientation is that this is the posterior pharyngeal wall. Here is the soft palate, and here's the uvula. This patient has a relatively open soft palate, but certainly their palate and uvula are fluttering around to create snoring sound. This is the posterior pharyngeal wall here. This patient has complete obstruction that's coming in from both directions, a front to back pattern and a side to side pattern. This is what would be considered complete collapse related to the soft palate. And drug-induced endoscopy is just one part of the overall exam. This patient had markedly enlarged tonsils, which you can see the edges of them right here and right there. And it turns out they did great with tonsillectomy alone, but I'll show you this because the airway never opens up. Those big tonsils don't go away. The uvula says hello to us. So that's the palate. That's not a surprise. We all know that that exists, and the palate is important. So here is the O for oropharyngeal lateral walls. Again, posterior pharyngeal walls up at the top of the screen. The tongue base is here, and the epiglottis is here. And if you look, they're not falling backwards to block the breathing. It's really just the sides of the throat are caving in. Pretty different pattern than the previous video and the next couple of videos.
Eric, it's John. Sorry to interrupt, but what makes the sides of the throat cave in? Is that just weak muscles, or is there a lot of fat in the neck, or what is it?
Yes. We don't totally know. I'll show you later how this is a real problem and a real limitation of therapies. But basically, I definitely see people that lose weight that have this clear up. There is fat deposition in the head and neck that's been shown by a couple of nice teams, including Terry Davidson, who's unfortunately passed, but he did some nice work to start this idea at University of California, San Diego. But basically, it's everything from muscle mass to fat weight to how we're made. Ronica did some work looking at our data showing that body position changes this, that if you're on your side, gravity effects can cause more collapse from a side to side pattern. And honestly, part of it is just how we're made. And so it's really differences in, you know, muscle laxity, probably that occur with aging. There's a number of factors that play a role. And so again, here's this side-to-side collapse. That's the O of oropharyngeal lateral walls, complete oropharyngeal lateral wall obstruction. So T is for tongue or tongue base. So this is the tongue base here. The view is blocked a little bit by the soft palate. So of course you need to move your scope around often during these exams. But if this is what's happening, you know, you probably want to treat that. If this is what's happening during natural sleep, you want to treat the tongue. And it wouldn't be surprising that someone would not do well with isolated soft palate surgery. Of course, these structures can contribute in combination. Here's the tongue falling back and sort of plastering the epiglottis against the posterior pharyngeal wall. I don't know how well the sound is coming through, but it's definitely some amusing snoring sounds. And then E for epiglottis. The epiglottis can fall back all on its own. And so the tongue base is way here. It's really just this epiglottis right here. And why this happens in about 5% of patients, we don't really know. Leslie Irvine, of course, one of our former residents who did some work looking at cadavers, and she elegantly showed that the same thing happens in the hyoepiglottic ligament that happens throughout the rest of the body, but certainly in the skin, that there's a decrease in elastin and collagen content associated with aging, and probably contributes somewhat to this laxity of tissues that are, of course, not just occurring in that ligament, but can be occurring everywhere else. Sometimes these patients actually don't snore because they're getting complete obstruction. So the sound is on for this patient video, but it's actually completely forming a seal in the pharynx. Okay, let's see, back to the show. There we go. Okay. There we go. So the idea behind drug-induced sleep endoscopy is it's a dynamic assessment during something close to natural sleep. And take my word on it, there's some, not that many studies, but there's some studies that are high quality showing that different things like muscle tone and other measures of physiology are similar, at least in the range of REM and non-REM sleep under sedation if it's done properly. The idea behind it is you want to visualize directly the obstruction, albeit under sedation. And the importance I always felt was that we had this region we call the hypopharynx, but it really contains these different structures. And it turns out that that probably is important, but you have these structures and they may be very different in terms of what's going on. And it was, you know, I picked up on it when I was at my fellowship and heard a talk at the academy meeting by one of those before, Winfried Hohenhorst, and I just was like, this is pretty cool. I'd like to learn more about it. So at that time, there were some studies looking at validity, and another study's been done after that, but greater collapsibility, you would want it to reflect reality. So it turns out greater collapsibility is seen under sedation in sleep apneas versus snores, and that's, you know, what happens in natural sleep because those groups are determined based on sleep studies. And then if you lump sleep apneas and snores together in a sleep disorder breathing category, you compare people who don't have snoring or sleep apnea, they had greater collapsibility under sedation, shown in another study. So it somewhat mirrors reality, at least. We did a couple studies, Krista Rodriguez-Bruno, one of our residents at UCSF, and then I led the other study looking at test, retest, and inter-rater reliability. I won't bore you with the details, but the idea is that it's, you know, repeatability, the consistency of the findings is not perfect, but it's not bad. It's in the range of what would be considered moderate to good. And so as I started my career, there were a couple of people that explored what I think is the most important thing for any evaluation technique is the correlation with outcomes. And a couple studies that were single center studies, smallish studies, looked at palate surgery and then multi-level surgery. And it was imperfect, but they did their best efforts, but at least there was some evidence that there might be some association between certain sleep endoscopy findings and results of surgery. Of course, there are disadvantages that are important to keep in mind. It's not easy. It requires sedation. You go to the operating room It's somewhat time consuming. You want to be careful with the sedatives. You don't want to go, I guess, get too excited and be too much of a rush, really, because sedatives can decrease muscle tone and decrease respiratory drive. You certainly don't want to artificially worsen sleep apnea and alter the pattern of collapse. And so David Hillman's group in Perth, Australia, and Peter Eastwood, they have shown, the first one is the similarities to natural sleep, and then the importance of avoiding over-sedation. And we use propofol because it has less of the decrease in respiratory drive compared to medications like midazolam that are used, at least partially used, as a sedative agent in many centers. So Catherine Green, shown there, is a former USC medical student who did a residency at the University of Colorado and came here for her sleep medicine fellowship. She's a surgeon, and she is now the head of the University of Colorado Sleep Disorder Center. And we're very proud of the work that we did and she led, looking at the question that really motivated me to get into sleep endoscopy research, of whether sleep endoscopy findings are associated with surgical outcomes. And last time I think I spoke with the department about on the research day we had in early 2018 or mid 2018, we hadn't yet presented the findings, but we did at the Academy meeting and now have published this multi-center study of drug-induced sleep endoscopy. It was born out of an International Surgical Sleep Society meeting in 2014. And we got a bunch of colleagues, 14 centers from around the world, N of 275, which sounds tiny, but we actually had some pretty stringent requirements. First is you couldn't have markedly enlarged tonsils. You had to have recorded and saved your sleep endoscopy videos. And of course, you have to have sleep studies before and after surgery, and they just couldn't have had previous surgery. And so what we did with 4 surgeons, we did blinded review of sleep endoscopy videos. So we didn't know what kind of surgery people had. We didn't know what the results were. We just looked at the videos, and we came up with consensus scores among 4 surgeons. And what we showed was that if you had any oropharyngeal lateral wall related obstruction, so partial or complete, you had a decreased odds of response to surgery. So the odds ratio shown there, cut in half. The same was true, or similar was true if you had complete tongue-related obstruction. And especially if you didn't do tongue surgery. And if you did do tongue surgery, we didn't have enough sample size to really show it convincingly, but it seemed like, at least by the point estimates, that doing some of the more involved procedures like removing tongue tissue were likely better results. We didn't clearly have enough data and couldn't show clearly that palate-related findings, so related to the V, or this complete concentric collapse that we all get worked up about, that we couldn't show that those findings were clearly associated with outcomes. And then with the epiglottis, because it's not that common, I mean, about 5% of people have isolated epiglottis obstruction, or at least epiglottis separate from the tongue. In 275, we had like 15, so that really wasn't going to be enough to really tease that out from a sample size perspective. So this was really I think, a landmark study showing what things were probably most important from drug-induced sleep endoscopy. First is that, oropharyngeal lateral wall obstruction is bad. Complete tongue obstruction is bad if you're doing these kinds of procedures. And so it's sort of something that needs to enter into the discussion with patients. So before that study was done, along came Inspire upper airway stimulation. And so this Inspire therapy is a fully implanted system. Involves 3 components shown here on the right. The pulse generator, which is sort of like a pacemaker, that's placed in the body. And there are 2 wires that are connected to it. One is the sensing lead that senses respiratory patterns. And then there's a stimulation lead that you can see here goes up to a portion of the hypoglossal nerve. The way this works is the system senses breathing and then delivers, during inspiration, mild stimulation to the hypoglossal nerve, which moves the tongue forward. People get a remote control that they just place over the pulse generator, turn it on at the beginning of the night, turn it off in the morning, and pause it if they have to get up to go to the bathroom, for example. And this is how it works. So it's an implanted system. Of course, the remote control is not implanted, but anyway, it's a system that's placed in the body. The major study published to support FDA approval was published in the New England Journal of Medicine, which we don't have too many articles in sleep surgery in that journal, but it was a single-arm study, 12 centers in the US and Europe, looking at safety and efficacy across different metrics like the apnea-hypopnea index, something similar called the oxygen desaturation index, a measure of quality of life, sleepiness, and then oxygen saturations. These were all study participants that failed CPAP. They had an apnea-hypopnea index, reasonable range. Importantly, they had body mass index that could not be above 32, a wide age range. The important thing for this therapy then and now is that you really can't have a lot of central sleep apnea, or what we call mixed sleep apnea. because the system relies on sensing respiratory effort. So people trying to breathe, otherwise the system doesn't function properly. It can't get a pattern in terms of breathing effort, which is important for the timing of the stimulation. And interestingly, this was the first study that required drug-induced sleep endoscopy before implantation to determine if you were eligible. So you could not have that complete concentric collapse related to the palate. So that front to back and side to side collapse that I showed you briefly in part of the video of the palate. You were excluded from enrollment in the study, and you today cannot get this therapy if you have that findings on your preoperative drug-induced sleep endoscopy. They had some initial evidence suggesting that this was true in a pretty small sample size, and there were a lot of moving parts. So I don't actually think it was the perfect decision, but it was a decision that was made. And so here's the way the study worked, just for a refresher, in case you've heard this before, but people had a screening polysomnogram sleep study, a baseline, and then an implant. They had left the device off just so healing could occur. And then about 1 month after surgery, they had what's called the titration polysomnogram, where they would figure out the ideal settings. People were started at a low level, and basically the therapy was left on over the first year. They had a repeat sleep study at 1 year that basically assessed how well it did, and that was the key outcomes that were used for FDA approval. It had a very interesting thing in that they took the first 46 people that responded well, so not everybody, but the first 46 responders, and they turned it off for a week in half of them, and then they turned it back on. But the ones that they turned off for a week, I mean, this 46 group, so the ones that had it left on versus turned off for a week, they did a repeat sleep study 1 month later, so 13 months, and then long-term follow-up. So here's what it looks like in an ideal, a nice picture shown, but basically here's a sleep study, all the different measures during an in-laboratory sleep study, the polysomnogram. We look at EEG, EMG of the chin. There's other things that are included as well, but the real keys are the airflow here, the nasal and the oral airflow, and basically you get these respiratory events, apneas shown here, where you don't get the normal breathing patterns, and these periods of apnea events associated down here on the bottom with drops in oxygen saturation. And so this is somebody with it off, and get the device turned on, and of course it looks beautiful because that's the image that's shown, but that's the idea behind this, is that you restore normal breathing and down at the bottom, normal oxygenation. So of course that's a picture of one study participant, but what were the results? So the 126 study participants, the mean numbers are shown here. Apnea-hypopnea index from 32 to 15, which is important. It's also interesting to see sort of the median scores, and that decreased from 29 to 9. And these were pretty compelling results that were reflected in the other measures of efficacy, like oxygen desaturation index, quality of life, and sleepiness. And these are pretty meaningful improvements, which of course led to FDA approval as well as publication in the New England Journal. Importantly, it's not just these 12-month results where a lot of things can happen over a year, but I think actually this study to me was more important. So this was this randomized withdrawal study where, again, it wasn't all comers, but here you have the numbers for the apnea-hypopnea index dropping from 30 to less than 10. Again, these are the good responders. But then in the light shaded bar, it was turned off just for a week, and you saw their sleep apnea came back. And then you had turned it back on at 18 months, their sleep apnea was pretty much cleared out, pretty much the same as it was at 12 months. And the same was true for other measures of efficacy. And to me, that was so compelling because clearly in a week, you're not going to have major changes in body weight, which can occur actually over a year, of course. But this was clearly the impact of the therapy itself. And it's certainly very reassuring that what we were doing with the therapy was helping people. So importantly, these are people that can't tolerate CPAP, and they actually really did use therapy. The therapy is a little bit better, people that responded well, but they were using therapy, and people had been a little dismissive of the idea that these people could do anything because, oh, can't even wear CPAP. Heaven forbid you'd wear this, turn on this device. But in fact, they had really good use. This is the self-reported, but with objective measurements, people do use it. 5-year results, not shown for many therapies in all of otolaryngology or really all of medicine, but really showing consistent benefits shown here: apnea-hypopnea index, sleepiness, quality of life, and here are different measures of response rates. Basically, there was people would move in and out of what being called responders, but on average, you still had a pretty good 70% response rate across the board that was pretty maintained, at least on an aggregate scale. So the reason that it works, and you're thinking like, well, you showed me a lot of things that can happen with drug-induced sleep endoscopy. Why does it, with this treatment that moves the tongue forward, why does it work? These were images from, the study was done with awake as well as drug-induced sleep endoscopy. And I want to focus first on the bottom. So as you go from left to right, you increase the intensity of stimulation, basically how strong a signal is going to the hypoglossal nerve. And so what you see is the airway progressively opens up. Now, you don't usually treat people at this level because that's uncomfortable, but this is level that seemed to be beneficial. Of course, it's one patient, but this was the findings that they looked at across a reasonable number of patients in the study, not everybody, but I think 80 patients in the study. And they showed that the airway behind the tongue, down low in the throat, that opened up in an anterior-posterior and a side-to-side pattern, suggesting that it treats all the different structures in the throat, suggesting that. It turns out that although these series of images looking at the retropalatal airway up high in the make it look like it actually does the same thing of opening an anteroposterior and a side-to-side pattern, it turns out there was much more improvement in the anteroposterior direction, suggesting that you're not going to get as much opening in a side-to-side pattern behind the soft palate, suggesting that this exclusion of complete concentric collapse, where you have not only front to back, but also side-to-side collapse, suggesting that that was actually the right way to go, and it worked out to be pretty fortuitous, because this study was done after the decision was made to exclude those patients and how to use sleep endoscopy. So I believe this, but I didn't totally take it on face value. So in fact, Phil Hewitt, shown here, who's now at Mass Eye and Ear as a sleep surgeon there, he led a similar study that we coordinated and got funding for through a few grant applications, looking at whether drug-induced sleep endoscopy findings are associated with upper airway stimulation outcomes. So I told you before that drug-induced sleep endoscopy is required before upper airway stimulation implantation. But really, its only use is to screen out those with this complete concentric collapse, which is roughly about 30%. And so you tell patients you've got about a 70% chance of having it work based on that New England Journal of Medicine article. But really, I thought we could do better. If we could use this information to identify those who had maybe like an 80% response rate compared to those with maybe only a 50% response rate. And so that's what we did. And so we just got accepted for publication last month. And what we did was we looked at that titration sleep study, which is not a perfect assessment of results because it's a very artificial setting. You're in the sleep lab. You change the settings a bunch, so it's not like you're looking at a whole night. You're looking at just a portion of the night. But anyway, everybody had it done. And so we were able from 10 centers to get 343 study participants, by far the largest study looking at drug-induced sleep endoscopy and upper airway stimulation. And overall, the results, a response rate was higher, although, again, this is an artificial setting. But we look at all the structures, and really I just highlighted in red the things that were the most important findings from a clinical perspective. In that oropharyngeal lateral wall-related obstruction, if you had complete, what we call O2, the response rate was only about 60% compared to 75% if you had none or partial obstruction related to the oropharyngeal lateral walls. And then if you had complete tongue-related obstruction, which was actually bad for other kinds of surgeries, you actually did really well. You had a better response rate, close to 80% versus close to 70%. And the idea is that, not that it's good to have more obstruction, but that if you have complete tongue-related obstruction, it probably was a big part of your sleep apnea. And in fact, what we did beyond the vote classification, we looked at the primary structure in our judgment based on the video, the primary structure that was sort of needed to be treated based on the sleep endoscopy. And if it was the oropharyngeal lateral walls, 60% response rate versus the tongue, 80% response rate. Not quite 50 versus 80, but it's 60 versus 80. And this is actually, I think, pretty meaningful in terms of how I counsel patients about their likelihood of response to upper airway stimulation. So this is what I do. As far as, I think the structure-based approach, I guess a little credit for, I think that contemporary sleep apnea surgery is thinking about a structure-based approach. We have these vote structures, and we try to sort of match the surgeries. And of course, traditional uvulopalatal pharyngoplasty, I don't do it that often myself, but there's certainly palate-directed procedures. I use a lot of these other palate procedures, which I won't explain, go through that again, because I've probably bored many of you too much, but there are these other techniques with expansion sphincter pharyngoplasty or lateral pharyngoplasty. They treat the palate, but they may also treat the lateral walls. In addition, this hyoid suspension that can also put some tension on lateral walls. Upper airway stimulation may work for people with partial obstruction related to lateral walls, and I think that's important, but we probably don't have great answers when people have complete lateral wall obstruction. We have this array of tongue procedures and upper airway stimulation, typically limited to body mass index below 32, although it can work in patients with higher body mass index. And then the epiglottis, we do have patients that have that. We operate on them. There's a couple of options. Hyoid suspension or partially removing the epiglottis can work. We still see maxillofacial abnormalities as a key factor in sleep apnea, and we can send people for maxillomandibular advancement. But I think counseling patients, for a long time, we've talked about body mass index, the fact that people with more severe sleep apnea don't always get their sleep apnea clearing up, or at least not as likely with surgery. Mandibles, people's small mandibles. I showed you that picture of the female earlier that we moved directly to maxillofacial surgery. Age, I think it's still an important thing, but I think now drug-induced sleep endoscopy really does enter the equation in terms of how we counsel patients, and it's been nice to finally show these things in some big multi-center studies. So we're building off in terms of really going forward in the future. The idea behind hypoglossal nerve stimulation is to move the tongue forward. And it's a unilateral stimulation with the upper airway stimulation system. And so Clemens Heiser in Germany looked at 20 study participants with upper airway stimulation during wakefulness as well as drug-induced sleep endoscopy. And during drug-induced sleep endoscopy, I don't know if anyone can tell me why. I think it's just sort of a part of what we see that's not actually a true thing, but there are many patients with right-sided hypoglossal nerve stimulation or unilateral stimulation that get anterior displacement of both sides of their tongue base in a very equal way. And I don't really know why, and no one does, but it certainly is not what we see in the Netter textbooks, that seems like there's some innervation of the contralateral tongue base and muscle with the hypoglossal nerve. But what's shown here is that about 25% in their sample, only 25% had ipsilateral movement of the tongue base, whereas 75% had bilateral. And the results were really good. This is just, on the right side is just the bilateral stimulation, but they had really good response rate. Opening of the area, the airway at the area of the palate, meaning that if you move the tongue base forward on both sides with hypoglossal nerve stimulation, unilateral hypoglossal nerve stimulation, the soft palate opened up better than if you had unilateral. So it suggests that, unfortunately, we don't have any way to predict this pre-op of what movement you're going to get, but you want to get bilateral movement. So what's the best way to get bilateral movement of the tongue base? Perhaps bilateral hypoglossal nerve stimulation. So it turns out that Nyxoah, shown here, has this device that's placed in the neck. There's no implantable pulse generator. There's no sensing lead, which may be a problem, but this is a company that has a bilateral hypoglossal nerve stimulation that's got FDA approval for a trial now, and basically is delivering bilateral stimulation and may get, ideally more bilateral movement of the tongue base. There is another technology that's had one study. It's about to go into another study, now owned by LivaNova. It's a simpler device to place because it has the pulse generator with just one lead. But the future hypoglossal nerve stimulation is probably here to stay. And the question is, what's going to work the best? Because obviously we want the best results for patients. But this is something you'll probably be hearing about going forward as people are exploring this. And there are other companies that are out there. They're not quite at the stage of FDA trials or on the precipice of FDA trials, but it's certainly something that is on the horizon. David Kent, another one of our sleep medicine fellows, is a surgeon, looked at ANSA stimulation. Take my word for it that increased lung volumes stabilize the upper airway. And the mechanism for this is that when you have increased lung volumes, it's not so much that it's a favorable point on respiratory airflow or anything like that, but it's that you're effectively achieving caudal tracheal traction through this tension effect. So you're pulling everything inferiorly here, and you're putting some tension on structures, maybe the lateral walls. And so Dave is a really bright guy who came up with the idea of, what about stimulating the branch of the ANSA going to the sternothyroid muscle? The idea being that you might get that some kind of tracheal traction. He's filed patents that have now been allowed and now have been licensed by Nyxoah. And basically he's taking this forward. So he's had a number of publications, which you may or may not have seen in Otolaryngology Head Neck Surgery from January. He first showed ultrasound localization of the ANSA branch of the sternothyroid is possible, and with localization and stimulation. He presented a case study, which the photos shown here, of basically someone at baseline under drug-induced sleep endoscopy with ANSA stimulation, basically getting a little bit more improvement, especially in the lateral wall stability, so not as much collapse there. And then they stimulated with baseline hypoglossal nerve stimulation, opening the area behind the palate, then adding ANSA stimulation, a little bit more opening. Just a single case, very intriguing. And then what they did was an acute study, and basically it was about 10 total participants, basically looking at, shown here, I don't know if it's readable, but ANSA stimulation, hypoglossal nerve stimulation, and then adding ANSA stimulation to hypoglossal nerve stimulation. And what you see is with ANSA stimulation alone, you went from a mean baseline maximal inspiratory airflow of 200 milliliters per second, and that increased from 238 to 711. So a pretty meaningful improvement. If you did hypoglossal nerve stimulation unstimulated, 140 to 400, and hypoglossal nerve stimulation 400, if you added ANSA stimulation, you went to 605. Now these were all different participants, so you're like looking at the data initially, you'd say, well, this is ANSA plus hypoglossal nerve stimulation, just 605, but ANSA stimulation alone is higher. The patients are different, so it's not suggesting that ANSA alone is better than the combination. But this is something that probably also you'll be hearing about going forward. I'm very proud of Dave and the work that he's done, and I wish he came up with the idea while we were here. Then USC would own the intellectual property, but he came up with this idea as he's been at Vanderbilt, just early in his career, innovative thinker and really creative. And this is something that is definitely going to be explored and perhaps really enhance the results of hypoglossal nerve stimulation. So this is something that building on some of my mentors, someone named David White, who was one of my mentors on my own career development award. He was at the Brigham, he was actually at Colorado, and then at the Brigham and Women's in Boston for many years. Now he's sort of retired from full-time clinical practice and full-time research. But endotypes are basically a mechanism, it describes the mechanism of endotypes are distinguished by having different mechanisms. And the idea behind endotypes is that we have people in sleep apnea, that we have sleep apnea, this repeated blockage of breathing, but really there may be very different mechanisms to explain why people are ending up with that. And so they've done a lot of work. Actually, the fundamental modeling of this was from Michael Koo, who's been a grand round speaker here. He's in biomedical engineering and on the faculty appointment in pediatrics. So one of his research labs at Children's. Atul Malhotra, who was at Brigham for many years, who's now at UC San Diego, is also was a mentee of David White and has continued this work. So there are multiple centers now doing it, including in Australia, actually. But anyway, the idea is that there are multiple factors that contribute to sleep disorder breathing. We've talked a ton about anatomy, and that's what surgery treats. And that's what people always have felt, that sleep apnea is caused by abnormal anatomy, or at least anatomical airway obstruction. But it turns out that there's some different factors that play an important role in sleep apnea in many patients. So one is the abnormal control of ventilation, what's called loop gain. Basically, more important probably in central sleep apnea, where people are not trying to breathe. There's sort of irregularities in the drive to breathe. But also in obstructive sleep apnea, ventilatory control can be very important. Some patients wake up too easily, and basically they have what's called low arousal threshold. And the idea behind that's important is that there are different stages of sleep. And it turns out stage 3 of sleep, sort of not the lightest stage of sleep, but a little bit deeper sleep, is actually more stable from a breathing pattern. So some people that wake up too easily can't get into this more stable breathing pattern. And if you wake up easily, if you have this low threshold for arousing, that can be very unfavorable in terms of getting into more stable breathing without airway obstruction. It turns out we have reflexes. And as the airflow decreases, there actually increase in the signal to activate the genioglossus muscle, which is the major pharyngeal dilator muscle that's been studied. And so some people respond differently in terms of having the genioglossus muscle become more active. There are other factors I mentioned, lung volumes and fluid shifts, but we won't bore you with that. But the idea is that these are common, these other non-anatomic traits that are being abnormal in about 2/3 of all individuals with obstructive sleep apnea. So how is this determined? So for a long time, and I'll just quickly mention, it was very difficult to do this. So when I was doing my career development grant, I went to Boston and I saw how they were doing it. They had a whole research lab, all sorts of wires in the genioglossus muscle, the catheters in the nose, and looking at epiglottic pressure. And you could basically collect all these data. So EEG, the typical thing that's done for sleep studies, but looking at genioglossus muscle and looking at coming down to epiglottis pressure, and of course, airflow. Over time, they added ways to do, and what you would do is you'd watch someone for a whole night. You had to hope for getting good quality data to estimate these different traits. Andrew Wellman, a different investigator at the Brigham, developed the idea of, hey, let's try to use with CPAP, take these sleep apnea patients and give them CPAP, and then we take away some of their CPAP and see what happens. And so what you see here is mask pressure dropping down, airflow progressively getting less here, breathing effort measured by epiglottis pressure becoming greater. So this is the drive to breathe until you get awakening. And so this is the drive to breathe. This is the arousal threshold, and that triggers these big breaths. You also can measure, look with these firewire electrodes in the genioglossus muscle, you can measure genioglossus muscle responsiveness. So you can get at some of these traits, and you can do it in a controlled setting. You can get enough data during a night. So loop gain, it turns out that the control of breathing looks at how much breathing response, how much increased airflow you get when someone awakens relative to the decreased airflow that occurs in this range here. And so this is sort of looking at minute ventilation. You can look at the disturbance, and then you can look at the response. And so these are the kinds of things that may be taken. I won't, again, go through these individually because it can get pretty complicated. But what you can do is you can create, and this oversimplifies things, but you can create these graphs of ventilation, so actual breathing versus ventilatory drive. So this red dot represents ventilation on CPAP, what the body wants. And so this is actually, it's not 1 over loop gain, it's actually -1 over loop gain, the slope of this curve, which represents the increase in ventilatory drive that is associated with your decreased ventilation. This is sort of what your body wants, almost like a demand curve. My background is economics, so I'll speak in supply and demand. So this is sort of what you want. The blue circle is what this person's actually getting, their ventilation off CPAP, what their anatomy dictates. And the slope of this line is what they can get, their increased ventilation as the ventilatory drive rises. It's almost like the supply of ventilation. And so the equilibrium should be right here, sort of where their desire for ventilation meets their supply. The problem is we have this green vertical line, their arousal threshold. And the problem is that if this arousal threshold is to the left of this equilibrium, they're gonna keep waking up. And if it's to the right, it's more stable. So they're gonna reach this point without waking up. And the reality is that this is oversimplified because it varies during the night, but the idea behind it is that we can change some of these things if we work. And I should take a step back. So the important thing is that doing this, incredibly tedious. They wanted me to start doing it when I was at UCSF, and I said, no, we're not doing that. But importantly, Scott Sands, who's at the Brigham now, he developed a way, an algorithm to measure these traits from in-laboratory sleep studies, which is a totally revolutionary thing in our field. Because if you can measure these traits, you might be able to do something about it because there are medications as well as oxygen can manipulate some of these things. So for loop gain, acetazolamide and actually oxygen, I won't go into all the details, but they can change things, change how the system works. Sedative hypnotics like Ambien or Lunesta can increase your arousal threshold to address this. And there are pharyngeal dilator muscles that you can change the response with multiple medications. So in general, in aggregate, these things have had poor outcomes in unselected populations. They've just sort of put a bunch of people sleep apnea in the studies, except for actually one study that looked at this genioglossus muscle responsiveness, taking for just one night, randomizing people to get this atomoxetine, Strattera, a medicine that's used for ADHD, and oxybutynin, an antimuscarinic, and showing pretty dramatic improvements, AHI of 28 to 7. And here's what you see is oxygenation as well. And really, everybody had good responses. The problem is this was one night, and these medications have terrible side effects. So these are not practical for broad use. But this was one of the first studies to show that you might be able to manipulate these traits and get some pretty good results across unselected populations. But we don't like unselected populations. So here are results from unselected populations looking at acetazolamide, isobuclone, so one of these sedative hypnotics, and trazodone, another sedative agent. And you see that the results are not very good. But there are some people who do respond. And my hypothesis is that these poor outcomes in aggregate reflect untreated traits, especially the most important one, which is anatomy. And it turns out that if you look at responses with surgery, results with surgery, as well as with oral appliances, I'll focus you here, that the responders shown in blue have lower loop gain than the non-responders, and that's important. So loop gain is important in response to surgery, And in both surgery and mouthpieces, low arousal threshold is bad. And if you combine treatment for both loop gain with oxygen and isobuclone with that, you actually, in those who have normal airway collapsibility, they also get good results. And so again, this is higher is better as far as normal airway collapsibility. These people did better. And so the randomized trial that I proposed and submitted last week for an R01 grant, basically taking people with moderate to severe sleep apnea who of course didn't tolerate CPAP. We're going to do sleep endoscopy and perform one of these newer palate surgery techniques. Take 150 people, get sleep studies afterwards. Some people will hopefully respond, but the ones who don't respond, we're going to randomize them to getting just acetazolamide alone, so decreasing their loop gain, treating one of these traits, or combined acetazolamide with isobuclone, treating loop gain and arousal. And we're going to look at how we change these traits, whether it's associated with basically rescuing surgery non-responders, and basically look at some other things like airflow patterns. And we have this team of Michael Koo and Atul Malhotra here who've given grand rounds, but Vince Gerbach in the Sleep Center, Wendy Mack, who many of you may know by email because she's coordinates the statistics program of helping people out with statistics. But here's Scott Sands, who developed this algorithm looking at polysomnogram in-lab sleep study data to estimate traits. And here's Andrew Wellman, who's done a lot of the work advancing this field. So in conclusion, sleep surgery, I think, has made substantial progress. Over the last 15, 20 years, we got more work to do, but the future should be both interesting and fun. And I think we've done some work in multi-center studies, which I think need to occur more commonly across all of otolaryngology and all of medicine probably. But there's exciting stuff coming with innovative technologies and combined approaches that are going to enable further sleep surgery.
Great talk, Eric. I had a question. Has anybody looked into the effect of Inspire on speech and swallowing?
They have not, to my knowledge. The idea behind Inspire is that you're not changing the anatomy. And so, of course, you have to not have any surgical complications, but that the idea is that you don't disturb this. Whereas anatomy altering surgery, as Josie, she'll be speaking about this, that there is this real potential for effects on speech and swallowing. So, but Inspire, the idea is that you should not have those impacts, and I have not seen those impacts in our implanted patients, and they've not been really reported as being widespread issues.
And the other thing is that if you do answer stimulation, you should be high and pulling the head down, but the swallowing is important to bring the hyolaryngeal elevation up, so it could be counterproductive, especially in elderly population who are more prone to have aspiration pneumonia.
Well, that's the question is it cause aspiration? You're pulling the thyroid cartilage primarily if you're doing third thyroid, but certainly the hyoid would be displaced as well. And you may be affecting swallowing. It is something that, the timing of it is not all night long. It's not like it's just continuous stimulation all night long, but you'd be delivering it intermittently through the night. Swallowing, we know, already decreases, so does saliva production decreases during sleep, but that's obviously one thing that you have to be very careful with. But aspiration has not been shown to be occurring after Inspire.
That was a really interesting talk, Eric. Thank you. The one thing comes to mind that you've got an advantage in sleep surgery over much of the rest of otolaryngology is your outcome measures. Because besides the fact you've got drug-induced sleep endoscopy with some, I guess, more qualitative assessments, you've got really good quantitative airflow measurements that you can document. When I think about like sinus surgery, I mean, we have the ways of documenting improvement are not that great. Cancer, I mean, I guess you can time to recurrence, time to mortality, but that's years, to get these data. You can get very quick objective data, and that lets you test things really nicely. It's very impressive. Great work.
Yeah, it's not quite as objective as we'd like sometimes, but there's night to night variation. There's a lot of problems with the apnea index, but it is a measure that's used, and we do have something. But we care about the qualitative a lot, actually, because of course that's where we would be getting a lot of our benefit with things. So anyway, I think I'm over time here, so I don't want to interrupt our next speaker. But anyway, anyone have any questions? I'd love to speak with you. Obviously, I care deeply about these things.